Okay, hi guys. So I'm Evelyn Laurie. You can call me Dr. Lawrence or Evelyn. I don't care, whatever you guys are comfortable with. And I'm going to give you just an overview of why I'm sitting in front of you and why I think you should be listening to me. So I graduated from medical school in 2008. I think this is my first slide. Yeah. I'm sorry, what am I saying? I graduated from college in 2008, med school in 2012. Went to OU for med school, did my intern year at OU also, went to radiology residency at Integris, and then got out of that finally and did a year of fellowship in breast imaging, so I subspecialized my subspecialty, and just finished in June, yes. Okay, so what do you guys need to know about all of this is, if you look at this, from me graduating college to me actually being functional like a working human being, it's 10 years. It's 10 years, okay? So I will applaud you guys for being smarter than I was. It's 10 years is a really long time. And I am subspecializing my subspecialty, right? So I'm really kind of pigeonholing myself, kind of. I do things a little differently, but it's a really long time. Okay, so my family, my kids, that's Ella and Elliot, and then my husband, and we were at a charity event called the Vintage Event, and I went to this private car collection in Oklahoma City. That's ridiculous. Some of these cars are worth $1 million a piece. It's crazy. And so we had this phenomenal dinner and got to go partying. Okay, so the last time that I was lecturing for the PA class, they had a test on Monday, so everybody's a little stressed out and ready to go, but you guys don't, right? Right. So this is a party weekend. And then, so the other thing I want to tell you guys is I'm going to be interactive, okay? I will probably call on people, pick on people, okay? So for the extroverts, man up, so that your introvert colleagues don't get picked on by me. Very much fun. And then if you have questions, stop me mid-sentence, we'll talk about it, okay? So here are the goals for the lecture. I think always it's good to start with the end in mind, okay? I want to give you guys kind of an overview of breast health, overview of what you guys are going to see, overview of what I do, and then I have a couple takeaways, okay? So let's start with the end, and takeaway number one, if you have a patient with a breast complaint, unless you're 100% comfortable, it's diffuse, bilateral, cyclic breast pain, and there's nothing going on, your breast exam is negative, it's okay. Anything else, send them to a breast imager. Just send them to a breast imager. You don't want to be the one who misses something. You don't want to be the one, I mean, just send them. I cannot tell you how many times I have scanned bilateral breast for breast pain to reassure a patient, okay? Number two, breast imaging is very sensitive. Breast issues are very sensitive. Every woman with pain thinks they have breast cancer. Every single one of them. Every single one of them. So just keep that in the back of your minds. When you see somebody and they are pissed off at your staff, they've already been a little bit rude, it's because they're on edge, because they think you're going to tell them they have breast cancer. And so, take a step back. And for all patients, because you're going to see these patients who are pissed, and they're mean, and you are tired, and I always diffuse that with being extra kind. And I speak quietly when I have those patients, which is different than my normal personality. So, and that way it kind of forces them to listen, okay? And then number three is my little soapbox is about hormones, okay? Every single one of you is going to have a patient ask you if they should be on hormones. Why? Why do people want to know about hormones? Why do people talk to you about hormones? Why do they want to go on hormones? Do you know? They don't understand. Yeah, definitely. Do you understand all the way? Do I understand all the way? But patients are going to ask you because they make them feel great. Oh my gosh, they're going to be out on a Friday night with their friends. Thank you. And somebody has just gone on some sort of hormone, and they're going to tell them, I have more energy, I feel better, I'm thinking better, and my libido is out the wazoo, and I feel amazing. And then they're going to come to you and say, my friend just said all this stuff, I want that too. Okay, so this is a huge area of medicine. It's going to get bigger and bigger. And I want you guys to know my perspective on breast imaging and hormones, okay? Which is that they're fine, with some caveats. Okay, so let's just talk about breast imaging. What do I do? There are several ways to look at the breast, okay? When I have my little chat with patients, I generally tell them there are three ways that I can look at the breast. One is with the mammogram, okay? X-rays. That's what everybody talks about, that's what everybody should be getting, blah, 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 okay? Second way to look at the breast is with ultrasound. That's live. At the fellowship that I did, every patient who came with a breast complaint saw a doctor. which is different than the vast majority of ways that it's practiced, because that was very time-consuming. Time-consuming means money-consuming, okay? And so I like that group, that's why I went there, because of that reason. And so I can look at the breast with an ultrasound, and I think it is very beneficial to have a doctor doing that, instead of an ultrasound tech doing it, and then you looking at still pictures. Because still pictures is like going on vacation and saying, okay, we're gonna go on vacation, here are pictures of the Grand Canyon, and you say, that's phenomenal, I feel like I've been there. No, never go there. So, that's kind of my soapbox. I think that it's good to actually have a doctor interact with patients. So, x-rays, mammogram. Ultrasound, number 2. And then number 3 is MRI. And a breast dedicated MRI, not all MRIs are the same, okay? There's an MRI that looks at your knee is different than the MRI that looks at your breast. They have different coils. You guys don't even know any of that. But just know that you want, when you're sending patients, you want them to have a breast dedicated MRI. And that involves contrast too, that you know. And then there's the last thing is PET CT. I'll touch on it briefly. Just know that that is a tool we have for staging of advanced breast cancers. Not all breast cancers get it. Stage 1 and 2 generally don't, but more advanced ones will. So know that there are multiple modalities, and we use them all the time. Sometimes we have to use all 3 to figure out what's going on, and that's okay. Okay, so screening. So one of the biggest parts that I want you guys to take home was understanding the difference between screening mammography, diagnostic mammography, okay? Because they're totally different. Screening mammography is what you're going to have patients going to do because they've turned 40, and it's time. You turn 30 and you have to get a pap smear every 5 years. What's the new recommendations on that? Something like that. 3. Okay. And so then when you get into your 30s, like I am, and I'm like, man, I feel old because I don't have to go get a pap smear. That sucks. So then you turn 40 and you're like, well, crap, now I have to go get a mammogram. That sucks. But it's for patients that are asymptomatic. They don't have any issues. Okay. So if you come and you have a patient, she says, I hurt right here. What's going on? You want her to go get a diagnostic mammogram. Okay. Or I have a lump. Okay. What if your patient has a lump and you feel it? You don't feel anything. What do? You believe her. You say, I don't really feel it, but I'm going to send you to a mammographer, and you're going to still go get a diagnostic mammogram, and we're still going to get to the bottom of it. Okay. Never ignore them. Never ignore them. Okay. Screening recommendations. Gosh, it's tricky. And you guys are going to have a ton of questions of these, and I think it sucks because we're not unified. Medicine is not unified. There are some places that say don't start till 50. There are some places that say every other year. There are some places, Europe does this, right? And then there are some places and some people, like actual breast imagers, who say 40 yearly. Okay. When I was in medical school, I picked up this little saying. Maybe I might have been the one who told me this. I don't know. But if you go to a barber, you're going to get a haircut. You're getting a lecture from a breast imager, I'm going to tell you every year starting 40, because I see those. Okay, my youngest patient was 27 when I diagnosed her breast cancer. I have a 46-year-old, I think her birthday was yesterday actually, who had bilateral breast cancer. It happens, okay? It happens. The 30-year-olds get breast cancer and it sucks. And so for me, I can't miss that group of 40s. I cannot miss them. And I think that we should be screening at 40 yearly. I've also seen breast cancers pop up within a year. Okay, you came in, you had your mammogram just like you're supposed to every year. Often people do it on their birthday, and that's great until it sucks when you have to tell them they have breast cancer. But whatever your MO is on getting your patients to get mammography, I've seen them have their yearly mammogram, and all of a sudden they have breast cancer. And 6 months ago their mammogram was fine. It sucks. It happens. Okay, so you have an asymptomatic patient, and they've just turned that special time of their life that they now need a mammogram, and you send them for screening. And then you get a report back from me that says either all is well or I see something. Okay, so just to throw out the terminology so you know when somebody talks to you, that's called a callback. That's what we call it. And so, that's all. Diagnostic, okay, so clearly if you are not asymptomatic, so if you have an issue, even if you cannot feel it, as the clinicians, if you guys can't feel it, don't ever just poo-poo it. Get it worked out. And that's where we get into the diagnostic, okay? Screening is with x-rays, screening is with mammograms. Diagnostic utilizes mammograms also, okay? This is where people get confused. Well, I just had a mammogram, so why are we doing another mammogram? You called me back, it's a callback, why are you doing another mammogram? And that's a great question. People are going to ask you that. Just tell them, well, there's specialized mammograms. We can hone in so that if we're looking for calcifications, or we can move and twist the breast in such a manner that I can make it look like something that it is or it isn't, and then I feel good about myself. But just know that we will use mammograms, okay? So just because they have a screening doesn't mean that they're done. And then we use ultrasound. That's probably the most typical. You do your diagnostic mammogram, you do your diagnostic ultrasound, and then we figure out is it a problem or is it not? Is this something that was just made up or is it not? Okay. So for these callbacks, one of the things I want you guys to know is your patients, you're going to, so here's how it works in practice. You order a mammogram, okay? And I give you a report, I give it a BI-RAD 0, it's a callback, they need additional imaging, okay? The vast majority of places will have it now be on you, and you call the patient, you tell them, oh my gosh, I got your mammogram results, and you need to go back. I don't think that's the right way to do things, okay? The time is money, and people don't take the time to do this. So at the Breast Health Network, where I was in Edmond, our staff took care of that. When we had a callback, we called them back ourselves. And we had a spiel, we deal with this all the time, you know, like, oh, they just saw a little something, we're not too worried about it, we just want to double check it. And that really helps patients not feel so crazy about it. We have the rule of 20s where I was. So callbacks, of those, 80% of the time it's going to be okay. It's a huge number. 80% of the time it's going to be okay. 20% of the time, I'm going to tell you getting a biopsy. Okay? Of that, of those 20%, 20% of those are going to be cancer. Okay? So now we're just getting tinier and tinier percentages. So when patients get this call, whether it be from your office, I would love it to be from the Breast Health Network, their office, they are totally freaked out because they're like, oh my God, I have breast cancer. You guys just remember, actually the vast majority of the time it's going to be okay, but we're just being thorough. We really want to make sure that you're okay. The vast majority of the time it's going to be okay. And so reassure them and you know. We had a system in place where if we thought it was going to end up in a biopsy, we would kind of mark like we have a high concern, which is nice. I don't think there's any way that you guys could implement that if you're doing it the way we are, because you won't. I mean, you'd have to press the imaging. Okay, so I just wanted to show you guys what mammograms look like because this is the most common screening modality and then diagnostic modality. In standard screening, we do, it doesn't hurt. Did somebody just say ouch? Did a man say ouch? I'm just kidding. Hope you're not introverted. So we do 2 standard views, okay? CC, up and down, okay? And then MLO, O is for oblique, and it is oblique, okay? It is not true lateral. Just, I don't know. I don't think you ever know that. But, so this is what, when I sit down to read a mammogram, this is what I'm looking at, okay? So on the right side, that's a CC view. On the left side, that is an MLO view, okay? The PEC is there. And then do you guys see at the very top of the screen, I don't know if it projects very well. Okay, so here's a joke in mammography. Whenever I project something like this, because I would do tumor board conference and all that stuff, nothing that I would ever see ever projects, okay? Like it's like these teeny tiny calcifications, and I'm like, just believe me, they're there. It's kind of silly I'm projecting this, but whatever. So on this screen, I can see the lymph nodes in the very top on the MLO view. On the left side, can you guys actually see that?
Yeah.
Yeah, maybe. Believe me. So you can get a view of the armpit too. So I don't think you need to know that. Just you've heard it once. Okay, everybody asked me about 3D. I have great news for you guys. So it used to be that insurance companies weren't all paying for 3D, okay? Which is kind of silly. So they'll pay for screening mammograms, that's covered 100%, and then a lot of them would pay for 3D, but sometimes the patient would have to pay a portion of it, okay? And that's changing. So as of next year, I think it'll be covered. That's phenomenal. Okay, so who needs 3D mammograms? I say everyone, absolutely everybody. Dense breasts especially, but absolutely everybody. Now, if you have like a person who has a super fatty breast, there's just nothing there, probably not. But the vast majority are going to need it, and you guys are not going to know, oh, this person has a fatty breast or this person doesn't have a fatty breast. You can't tell by looking at somebody, by the way. So I've had patients tell me, I'm like, my boobs are big, so they're probably fatty. I'm like, no, that's not how that works at all. And then I'm going to see if I can play this because I wanted to show you guys what a 3D mammogram looks like versus a 2D. So again, this is a 2D mammogram. These are still images, okay? So when we acquire this image, we take one x-ray, in these views, one x-ray, and then all the tissue stacks upon itself, okay? 3D takes multiple images, multiple x-rays, and so when I did my spiel, I'd say this allows me to take a little video of your breast tissue. and I take 1 millimeter slices, and then I can look through that breast tissue. So if there's something that on the 2D kind of stacks upon itself with the 3D, I can separate that and say, oh no, that's not an actual finding. That's just normal breast tissue that happens to be stacked, which happens all the time. So 3D really helps us because it will decrease the number of callbacks we do, because we can tell that it's not Okay, so this is a 3D, and this is as it is scrolling. Let me see if I can make that bigger. Okay, so it's not going to project, right? It's nothing I do on mammography ever projects well. So can you guys kind of get the sense that we're scrolling from one side of the breast to the other? Okay, so this is how we look at a 3D mammogram. It's very, very cool. And can you guys kind of get the sense that like there's like a little clump of tissue in the back, and if that had kind of lined up just perfectly, like right there, that actually might be a thing. But I don't know. This is a video I pulled offline, so. But we can kind of tease apart, like, oh no, that's just 2 pieces of breast tissue, not one thing, if that makes sense. How do I make it actually go to projector mode? If I push this, no, start from the beginning.
Do slideshow. Right there.
Thank you. So, and then what this is showing is exactly what I'm trying to say, is that on the 2D image, you can have, breast tissue cancer, and it looks like this mess of a conglomerate, and on the 3D, you can separate those 3 things out and say, oh, that's bad, but these are okay. Okay, ultrasound. I just wanted to show you guys what an ultrasound looked like. I don't think that you need to know anything about it. Know that we can look at the armpits really well. Okay, so we'll get patients all the time with armpit complaints. It has nothing to do with the breast. We still double check their breast, especially if they have a large lump or something like that. But we can look at armpits. That's, I think, all we're going to know about that. And then breast MRI, again, just know that this exists. And I get patients all the time. My mom, I'm a radiologist, right? My mom she needed a scan for something, and she just called me. She was like, okay, well, the price is $1,000 here or $400 there. Can I go there? And I was like, no. Why are you trying to cut corners? Don't cut corners. Don't go to Joe Schmo's MRI machine and ask for a breast MRI. Not going to happen. And breast particularly. A lot of other stuff is probably okay, open MRIs and whatever. But don't cut corners on health unless they really have to. Okay. So thankfully my mom got the more expensive thing. I'm probably going to have to give her a nice Christmas present. I don't know. But she didn't fall into the trap because so many patients are going to say that, oh my gosh, well, it's a little expensive. But breast especially. So to read breast MRI, general radiologists generally don't read breast MRI, okay? General radiologists pretty much hate breast imaging. Unless you are in a very small minority of us who like it, they don't want to do anything with it. And so go to a breast center, have your patients go to a breast center, have them do a dedicated MRI, and have a dedicated breast imager reading that MRI. So like at every step it has to be dedicated. And that's really all you need to know. Just know that it's very finicky and you got to find this. And then the other thing is that this uses contrast. Okay? So in radiology world, we give contrast for a lot of things. Okay? At the end of my lecture, I'm going to give you my cell phone number. If you guys ever have a question about, oh my gosh, I have no idea what to order, call me, text me. I don't care. Call me, text me. I'd rather your patients be taken care of. And I can walk you through radiology. Nobody ever lectures about this. Nobody tells you about what to do. Even in med school, I didn't learn any of this crap. I had to go through residency and take 10 years of my life. But ask me. So contrast allows us to see tumors, okay? By and large, we can see tumors without it, but there are certain characteristics that the contrast is utilized with that allows me to kind of tease out good from bad, okay? I'm telling you all this because contrast is excreted by the kidneys, so you have to have good kidney function, okay? So not everybody will qualify for contrast, but we need it for MRI for the breast. The other thing to know about MRI is if they have a pacer or a defibrillator, they keep it. And especially breast. There are, yeah.
What do you do if they don't have good kidney function and can't get contrast? Do you still do the MRI, or you just go to something else?
Yeah. Yes. I wouldn't bother with it. We would go old school before MRI came around, and we would do ultrasound. I have patients that I have the same problem because they have a pacer, and I can't do it. And so, in those cases, if I'm really worried, we can go to CT. Okay, and then just evaluate and do other things. But I'd scrap the MRI. And then the surgeons, so the FDA, if you have a patient with implants, nobody tells implant patients this. This is brand new, but everybody knows, but nobody tells them when they get their implants. One, implants have a shelf life. You guys know this? Okay, okay. So implants have a shelf life, right? 12 years, 15 years, whatever. Some people say 10. But they're going to have to be redone, okay? So I have patients all the time with like implants older than me. It's okay. There's just an increased risk of rupture. Okay? If it's saline, you can get saline. Your body will just absorb it, and the breast will shrink. And that's it. No big deal. Silicone can rupture, and then you can start getting some issues. But what we've proven, this is a soapbox, so you guys don't have to just hear this one time and you'll be fine. So we have disproven any connection with a ruptured silicone implant being bad. Okay, so we used to think autoimmune diseases and all this other stuff, and that's all. It's fine. But what is actually recommended is that every 3 years they're supposed to go get their implants checked with an MRI. So guess how many patients are doing this? Of course not. No, nobody does this. There are a couple of patients who do this, but the only thing to know is that a check for an implant is very different than a check for cancer. We don't use contrast when we're just looking at an implant, okay? And I just told you, if I didn't have contrast, am I going to be using an MRI to look for cancer? No. So, we won't put virus on MRIs that are for implants only because they don't give contrast. So just know that too. And I guess have in the back of your mind, if somebody has an implant problem, just send them to a breast imager. We'll take care of it. Or you can send it to your surgeon. And then they'll send it to us, and we'll take care of it. Okay, so this is a PET scan. I just wanted to show you guys what this is. Okay, PET scan uses a glucose derivative. I had a really interesting conversation with a patient a while back. Have you guys talked about glucose and cancer at all? No, nobody does. Okay. So they think that sugar, right? So we're starting to come out with this stuff. Has anybody heard the term type 3 diabetes yet? No, nobody does. It's around. It'll come out 10 years from now. You remember that I told you. So type 3 diabetes is linking sugar to dementia. And they are also linking sugar to cancer. Okay? And so I think that's probably true. I don't eat processed sugar. I eat like a modified Whole30 diet. And I try not to let my kids eat sugar, but that doesn't always happen. I thought I was giving my son a Nilla wafer for the first time, and I'm like, my grandma used to give them to me. I'm so excited to like share this experience with him. And I'm like, oh my God, kid, try this. And he looked at me and was like, no thanks. And I was like, no, but buddy, try it. And he's like, I eat that at school. And I was like, oh, okay. But, so glucose. All right, why am I on this tangent? PET scans. FDG is a modified glucose molecule, okay? FDG is avidly sucked up by cancer, okay? So I had a patient tell me, we're doing this talking thing, and I really like kind of fringy medicine stuff, like the glucose stuff, type 3 diabetes stuff, hormone stuff. I think it's phenomenally interesting, and I think it's going to be the future of medicine. And so she and I were bantering, because most docs don't know this stuff. Right? We're taught how to fix diseases, we're not talking about wellness. And she goes, yeah, I really think that is true, that glucose feeds cancer cells. And then she told me, a radiologist, why else would they use a glucose derivative on PET scans? And my mind was like, that makes perfect sense. It's avid. It avidly takes this up. So it's bright. And so, anyway, that's my soapbox on that one. Okay, so I know you guys just did your clinical stuff, breast exams and pelvic exams, like the favorite day of class, especially for the guys in here. That was a joke. It's not. Nobody likes it, not even girls. It's okay. So I just wanted to touch again on the anatomy of the breast. I don't think that you guys need to know this. I really don't. Know that the breast is composed, when I give my spiel to patients, the breast is composed of 2 types of tissue, right? Which is totally dumbed down. There's more than that. Doesn't matter. But there's fat, and there is glandular, I call it working tissue of the breast. That's all you really need to know. Okay? The glandular tissue is where all the cancers arise from. Okay? Specifically the terminal ductal lobular unit, TDLU. You don't need to know that. And this is how it's shaped. I really think that that's, unless, does anybody want me to go into more detail of the anatomy of the breast? I don't think I'm gonna take the full 2 hours. We can detour and do whatever you guys want. I just don't think that it's really beneficial. There are a couple things that I do think you need to know, okay? Lymph nodes, where do the breast lymph nodes, where does cancer drain? Which lymph node? There's only one exception, colloidal tumor, that's hematogenous. That's my board question, honestly, your board question. So just, yeah, no, you guys are, everybody knows this, right? The Komen Foundation has done a phenomenal job of educating women, okay? So they're gonna come to you and say, oh my gosh, I feel a lump in my armpit. I have breast cancer. Because that's how they've already been trained, okay? And, you know, sometimes that's true. Sometimes, vast majority of times it's not, right? Because this can be enlarged by, like, lots of different things, okay? One of the breast imagers that I trained under had, like, a hangnail or something, like some sort of cuticle issue. I swear to you, she had lymphadenopathy in her armpit. I swear. And so there's lots of things. Yeah, there's lots of things to do. So one of the things that I always talk to patients, because they will come in and they're like, oh my gosh, I think I have breast cancer. I have this lump. And, you know, I talk about, have you had any injury? Have you had any infection? Have you had any whatever to your arm or chest? And then that kind of helps tease things out. On breast exams, there are things that I think you guys should know. Okay, one thing is what I already pointed at, right? If you have a patient, and I do this, I do this all the time. If you have a patient, and particularly a young patient, that says, I have a lump, and you go and you palpate, you don't feel anything. Okay? You have a breast imaging. I palpated so many breast cancers, and there are times that I'm feeling around, and I'm like, I have no idea what she's talking about. I don't feel anything, right? And I have a little more confidence in my exam than you're gonna have in your exam. I've done it a lot more. It doesn't matter. I would never say I'm done. I would still scan her. I would still put the ultrasound probe on her and scan her. That's what you guys need to do, okay? So if you have somebody coming in, and we're gonna talk all about complaints and all this other stuff, right? If you guys have somebody, just don't stop. If they think they feel something, have them come to me. And actually, we go so far, if it's a young patient and they are saying, I feel this, I swear to you I feel this, and I put the ultrasound probe right there, and I show them on the screen, I'm like, I don't see anything, this is just normal anatomy. I say to them, but I tell you what, you're still feeling something, I still believe you're feeling something. I'm gonna bring you back in 3 months. We're gonna check it. If something rears its head, I'll know about it. But just as peace of mind for them, for peace of mind for me, okay? And that is not anywhere in the BIRADS manual. That's something that the group that I train under does, because we're very kind of hand-holding this group does. Okay, so basically, working glandular, okay, you have the ducts at the periphery of the breast, okay? So think about this. You have the ducts, it's like a tree that branches. You have the lobules at the periphery. Where do most breast cancers start? At the periphery, exactly. Because most of them arrive in the terminal duct of lobular epithelium. So just know the cone, it's that outer edge of the cone that I'm always worried about when I'm focusing on it. Those lobules are the ones that make the milk. That milk gets made, and then it gets sent towards the nipple, to the ducts. Complicated, it's not hard at all. And then you have like a little reservoir right behind the nipple that is called the lactiferous sinus, and it just kind of acts truly as a reservoir, so that when you're nursing, and some patients will tell you they have like a letdown feeling. That's where that lactiferous sinus is just kind of enlarging, expanding as a reservoir before you start nursing. And then, of course, the nipple has multiple openings. The areola has multiple little glands. They're called Montgomery glands, okay? Patients will come to you because some of them can get little sebaceous buildup in them. They can get infected. Again, at the end of the day, if you're unsure, send to a breast imager and we'll take care of all of that stuff. Those Montgomery glands serve a function. They help lubricate the nipple during nursing. I don't think you know that. That's about it. Does anybody have any other questions? Or do you want me to go into any other detail of breast anatomy?
No, wait, there's usually some type of more question about the tail of stents.
Okay.
You know, but why the PA board loves to question on that, I don't know.
Oh, I can tell you. Yeah, because that's an outdated term. That nobody uses it.
That's why it's on board exam.
Yes, because Yeah, okay, so anytime you hear an outdated term, you guys need to write it down because it will show up on your board. That happens to me all the time. Okay, so the tail of Spence is the axillary tail. That's what we call it now. But you're going to hear that. You're going to absolutely hear that. Okay, so I will touch on that. That's really, thank you for bringing that up. This is actually great. So in the axillary tail, okay, so breast tissue, the vast majority of the breast tissue is in the outer upper quadrant. Okay, oh, and I have one more pearl for you guys. Okay, we have to touch on, and that's a clock face. Don't let me leave the slide until I talk to you about the clock face. So the axillary tail, the vast majority of breast tissue is that upper outer quadrant. Okay, 10% of patients are going to have breast tissue in their axilla, in the tail of Spence. Okay, in their axillary tail. That is why we oblique our radiographs. That is why we do that, because I want to, one, see this outer upper quadrant the most. So I'm most interested in that, because where the most of the breast tissue is, can you imagine just statistics? You've got more breast tissue in one place, more cancer is going to be there. Okay. And so it's really important. And then you'll have patients talk about swelling of their armpit and all this other stuff. Again, send them to me. Send them to a breast imager. We'll take care of it. And it could be, especially the cyclic. You know, oh my gosh, every time I have my period, my armpit hurts. Oh my gosh, my armpit swells. They're probably in the 10% that have breast tissue up there. Okay, so I just said upper outer quadrant. Okay, there are two ways that breast imagers think of the breast. Quadrants is literally that simple. Upper, lower, inner, outer. That's it. Okay, you sign it. It's easy. Or clock face. When you have a patient with a breast issue, seriously write this down. This is huge. Okay, is everybody paying attention? Everybody awake? Okay. Tell me what quadrant the thing is. That's all. Truly, that's it. You don't have to get fancy and use clock face. I don't care about any of that stuff. But I can tell you my biggest pet peeve is when I get somebody and the clinician has felt a lump. I don't even know what the breast is in. God, what am I going to do? Or I know what the breast it's in, and I have no idea where. Then what do I have to do? Scan everything. And then take some more time. Time is money. So if you guys can just tell me quadrant, you will be a breast imager's best friend. Okay, we're amazing people, so be our best friend. And then how we do it, how I record it out is clock face. Okay, and this is confusing as crap because the breasts are different. Why did they do this like this? I don't know. So the clock face is like you're looking at a patient. Okay, 12 o'clock and 6 o'clock are easy. But 3 o'clock and 9 o'clock are hard because it follows the clock face. And so 3 o'clock, okay, so this is going to confuse me even just trying to tell you guys backwards. Yeah. Yes, thank you. What color?
Pink.
Okay. In radiology, everything left and right are always switched. Okay? So in real life, I suck at left and right because like my brain isn't smart enough to subtract whether or not I'm in real life or in radiology. Okay, so this is my right hand, okay? Right side, left side, okay? So you are looking at a patient facing you, okay? That's their right side, right? Okay, good, the left side too. Okay, so you have breath. Okay, so this is their sternum here. This is their arm. Okay? Why is this confusing? Because the medial aspect of the left breast is 9 o'clock. The medial aspect of the right breast is 3 o'clock. Confusing. So, if you get fancy, do it like this. But if you can just give me quadrant, I'm here. I will find the breast cancer if you give me the quadrant. I will find the breast cancer if you don't give me the quadrant, but it makes my life a little harder. So, okay, does anybody have any questions on that? That I think is probably the most important thing. Just know that there's quadrants. Tell me what quadrant, and then we'll leave that for now. Remember tail of Spence, otherwise all now called the axillary tail. But it'll show up on your board because it's antiquated. Okay, I wanted to touch briefly on the histopathology of breast cancers because it's confusing and patients will ask you about this. And so I actually, in my residency, I spent some time with a breast surgeon Oh, the other thing that you should know about breast surgeons is that everything about breast, if you guys get one take home, everything about breast is very finesse and sub-specialized. So there are breast dedicated surgeons, right? There are breast dedicated radiologists. They are, medical oncologists that do a ton of breasts, and that's kind of their little area, okay? And so if you're talking to a patient, and if you're in rural America, it sucks. A lot of patients will come to the city for this, but know that there are breast dedicated surgeons. And you should be sending your patients to a breast dedicated surgeon, not just anyone. Unless you can't, and that's fine. Or they're, some patients have their own ideas. But I spent some time in her office, and every single patient that she had, breast cancer patient she had, she showed this chart. And I loved it. So on the left side of the screen, see, I can't tell up there. It's just normal breast tissue, okay? So what you're looking at is, remember there are lobules that made the milk. There are ducts that took the milk from the lobules to the nipple. That is a cross-section of a duct. Okay. So the little epithelial cells that line it, they're all happy. Well, because of insults or genetic or whatever, one of them becomes unhappy. And they start going down a path to breast cancer. And so the top middle is ductal carcinoma in situ. That is the most common thing that you will encounter. Okay. What does that mean? That means that you have cancerous cells that have still respected the boundary of the duct. Okay, this is big. Cancerous cells respected the boundary of the duct. So, on the top picture, none of those cancer cells are moving out. Okay? That's why we call it a precursor to cancer. Okay? Once those cancerous cells no longer respect the boundary of the duct, then it is full-fledged invasive carcinoma. Okay? And that's what the bottom middle is for. Those cells are no longer respectful, and they can get out. Okay. They get out locally, and they travel to the axilla. And then if they go elsewhere, that's at that far right one is trying to show that they spread everywhere. Okay. Cancer cells need blood to survive. True or false? So they're feeding off of blood, okay? So if you have an invasive cancer, it has access to the bloodstream, okay? Even if it's localized, it still has access to the bloodstream. And we are not so good to be able to find one cancer cell, okay? My mentor, Deborah Mitchell, she's phenomenal. She would tell patients, cancer cells have to be a recognizable size and shape before I can find them, okay? So they say, oh my gosh, I've been getting your mammograms and this cancer just came up. And she said, actually, it's been there for a while. And then they're like, well, what the hell? I just got my mammogram. I came to you to get my mammogram. She said, no, but it has to be a recognizable size and shape. Okay? And that depends on how fast they grow. Ideally, we want to catch the ones that are growing slow. The ones that are growing fast are the ones I talked about that show up within a year. The rest of them, they've been there. Okay? Did I miss them? Sure. Would everybody have missed them? Yeah. Because they're not a recognizable size or shape. Okay? And cancer goes 1 cell to 2, 2 to 4, 4 to 8. That process takes time. Okay? Depending on how long it is when you can get into low, intermediate, high grade, all this other stuff that you guys don't even know anything about. Just know that that's a thing. Okay, so DCIS respects the boundary of the duct. Invasive cancer does not respect the duct. Invasive cancer has access to bloodstream. So you can have cells hiding out, okay? And we can't see every single cell, which is why those patients will get chemotherapy, or they will get hormone blocker at the end of their treatments. And there's such fancy stuff nowadays, it's phenomenal. We can take the genetics of the cancer, right? You give me a 5 millimeter cancer. How big do you guys think the cancer cell that I biopsy? Just out of curiosity.
Greater than 1 centimeter?
Oh heavens, I hope not. Yes, I biopsy 1 centimeter cancers all the time. I hate that though. If it was like a 3 millimeter cancer, I'd put a needle in it. Right? That's like this big. It's crazy. We can see a lot of things, but we can't see everything. Recognize the size of it. And I think that that's pretty much all that I want you guys to know. Depending on stage of the cancer, early stages don't get PET scans, but we're looking for metastatic disease, okay? Beyond regional, spread of the armpit. So bones, liver, I think I have a slide on that. Okay, so talking about the different types of breast cancer. DCIS is going to be the most common one that we see, okay? That's the one that we pick up with mammogram. I have patients all the time that talk to me and they say, a mammogram is radiation, I've been doing my homework, I don't want radiation. I want an ultrasound. You use ultrasound to look at the breast, I know that I've been doing my homework. I say, yes I do. But I still think that you need a mammogram, and this is why. DCIS, actually, I'll do another drawing. Now you guys got me on this board thing. Okay, so this is a duct, okay, branches, lobule, okay, TDLU, terminal ductal lobule units, right here. Okay, so you have breast cancer cells that are starting to build up, okay, but they're respectful, they're not breaking through, and so they're going to start building up here, just like that picture shows. Okay, breast cancer cells, any cancer, needs a lot of. Okay, good. I'm sorry, I forgot to charge my watch, and so I want to make sure that my cleanse is in. That's on. So sorry about that. Cancer cells need blood. Cancer cells grow fast. Cancer cells will outgrow their blood. Okay? What happens when a cell outgrows its blood? Okay. Cancer cells calcify when they die. Okay? Breast cancer cells, model cancer, breast cancer. And so what happens is you will start getting calcification below here. Okay? And these calcifications, they're called microcalcifications. They have nothing to do with the level of calcium in your blood, but they will start showing up, and that's my indicator that something's going on. That's how I know. That's how when I look at a mammogram, how I know. Okay, these are microcalcifications, like millimeters, right? Like a 3 millimeter breast cancer. That's crazy. Think about that. It's teeny tiny. You're not going to see it with any other modality. You're not going to see it with ultrasound. And so that's why with patients, and they're going to ask you guys this. This is an important thing. They're going to say, well, I know that you can do screening ultrasound now. I just want a screening ultrasound. I don't want radiation. Dr. Oz said it was bad. And you're going to say, well, they do screening ultrasound, and that is a great tool to supplement the mammogram, but you need a mammogram, and this is why. The earliest form of cancer calcifies, and there's no other modality to see calcium better than a mammogram. And that radiation is teeny tiny, and it's not directed at your thyroid, and it will be fine. And now you can leave my office so you can go catch your Dr. Oz. So I think that that's the other thing. And the other thing that you guys need to know, and I didn't even put this in my lecture, that we do have screening ultrasound. Okay? At the beginning of the lecture, I told you mammograms are for screening, and that's changing. We have screening ultrasound. It is very good for dense breasts. And in a minute, I'm going to touch on high-risk populations. And we use ultrasound in conjunction with MRI. Gold standard is mammogram and MRI. But what if I have a patient who can't have an MRI, and I go back to ultrasound? Old school, okay? And so for patients with really dense breasts, that might be something that you should consider. And you're going to start seeing this on the reports. This is getting more and more popular, okay? Do you guys want to know about the background? I'm still good on time, I think. So there was a woman in Connecticut who was getting her mammograms because she had turned how old? 40. Yes. Now you're 40 and you're like, crap, I gotta go get a mammogram. And she was doing it. She had very dense breasts. Okay. Then she discovered she felt a lump. And they did an ultrasound, and she had breast cancer. And so they went back to look at the mammogram. That's what we do. What did I miss? What did I miss? And you can see it. Her breast tissue is too dense. Okay? The breast is made of two types of tissue, fat and working glandular tissue. Fat is dark on my mammogram. Okay? This matters to me because working glandular tissue is white. What else is white? And masses. All breast cancers. All of them. So if you have a ton of white, it's a lot harder to see. Okay? This lady's cancer was, I don't want to say missed. That's not the right word. You couldn't see it. But you can see it easily on ultrasound. So it turns out she's like the senator's wife or something or other. I don't know. She's somebody important. And guess what? When crappy things happen to important people, laws get changed. Okay. So she changed the law. And she said, had I known that I have dense breast tissue, I would have gotten an ultrasound. Okay? And I want all American women to be able to do that. And so this is the new law that went into effect. Oklahoma passed the legislature to put that into effect. And what that means for your patients is that on all of our reports, I tell patients what kind of breast density they have. You have fatty. You have scattered fibroglandular. You have heterogeneously dense breast. This may obscure a breast lesion. That's what I say. Heterogeneously dense breast, this may obscure a breast lesion. Or you have extremely dense breast, and this can definitely obscure a breast lesion. And so Oklahoma passed the legislature that I had to tell people this. Okay. And then what did they do? They did not pass corresponding legislature to make the insurance companies pay for it like they pay for screening mammograms. Okay? Vast majority of insurance companies will cover it, but it is applied to the patient's deductible. Okay, so you're going to be out of pocket a couple $100. And so because they did not have the legislature in place to make the insurance companies pay for it, if you have dense breasts, what I say is, I suggest that you do this. I don't recommend it. It seems stupid, because it is. But just know that it exists. Just like we just passed legislature that all the insurance companies are kind of going to cover 3D as of this year, next year. This will come in and everybody will get taken care of. I bet, I hope. But know that your patients are going to ask you about it. And it is a phenomenal tool. And then what you're going to say is, yes, I think it's a great tool. You're going to look at their mammogram because they're 40 and they're responsible and doing the right thing. And you're going to say, oh, you have dense breasts anyway. So I think it would be a good idea. But just know that you might be out of pocket a little bit because it's going to apply to the future. Okay, all right, so this is the slide we were just on before I went backwards. I kind of alluded to how fast the cancers grow is a marker of how aggressive they are. The faster they grow, the more aggressive. That's what we call it high grade. The least aggressive, low grade. Seems simple enough, right? And then that's going to be your most common. DCIS is very, very common, okay? IDC is the invasive. They no longer respect the boundaries of the ductal. And then you're going to have these funny things, and all I want you to do is know that they exist, okay? LCIS exists, lobular carcinoma. So what did I tell you guys? The vast majority of the breast cancers happen at the TDLU, terminal ductal lobular lumen. The vast majority of them are ductal, but the lobule can go awry also, okay? So know that you have lobular cancers. And lobular cancers infer a greater risk of bilateral cancers. I don't think you really need to know that. Because if they have this, they're hooked up with a breast measure, and you know that. Okay, so there's additional types of cancer, and I want you guys to know the first two. I don't really care about even phylloides. Phylloides is a rapidly growing tumor, okay, but anytime you feel a lump in somebody, anytime they feel a lump in somebody, it doesn't matter, you're going to send it to me anyway. The faster it grows, you don't have to be totally freaked out, I would be. But it could be a really aggressive cancer, it could be a phylloides, which is aggressive, or whatever. Okay, for you guys, though, Paget's disease and inflammatory breast cancers, you have to know these two. Okay, changes of the skin. I'm about to go through a whole bunch of things that can go wrong in the breast, but know these two. Paget's disease. If you have somebody who comes to you and says, my nipple is scaly and red, that could be a Paget's disease and has to be evaluated. Has to be evaluated. So just know that, okay? Don't just call it eczema. You can for a week. Put some cream on it if it goes away. Okay, rules in breast imaging. If it goes away, it's okay. By and large, right? So all patients tell me, oh my gosh, I'm coming in for this lump under my armpit, and it came up and then went away, or my doc put me on an antibiotic and now it's gone. But I think I saw breast cancer. It's okay. Good news is the cancers don't just go away with antibiotics. So if you have somebody, and I've treated a patient, I had a patient come in that had a scaly red nipple, and she had been putting frankincense on it. Okay, essential oils are everywhere. Huge. I like them. But a lot of patients don't know how to use them. Okay, you dilute them. And they can be very, very caustic to your skin if you don't dilute them. So this woman was not diluting, she was putting a bunch of frankincense on her nipple because it was itchy. Okay, whatever. Diluted, olive oil is probably more healing than hard drink, but whatever. And I wanted to, I did a workup on her to make sure there was no underlying Paget's that I could see mammographically. She didn't let me ultrasound her, and I brought her back. I said, okay, you're going to stop in this. We're going to get some very healing balm, and if this goes 100% away, I'm not going to biopsy you, and I'm not going to bring you in. But if it doesn't, you have to come back and biopsy. And it did. It was totally the frankincense. So just know, I'm like, yeah, you can be excellent, but if you have something that has a non-healing or doesn't go away, give it a little bit of time, it's fine. A little bit of time is a couple weeks, max. But otherwise, send them in because there's pageants disease. Just know, I'll put a picture here soon. Okay, inflammatory breast cancer is the breast cancer that your patients will know about because it's scary as crap. And it's all over the internet, right? Dr. Google has inflammatory breast cancer all over. And the scary thing about it is it happens to young women, and it looks like an infection. Okay? You see an angry breast, ask yourself, how old are they? Are they lactating? The answer is yes, probably mastitis or okay. But I always bring those patients back to make sure that I'm not missing an inflammatory breast cancer hiding out. Always. Do not sit on inflammatory breast cancer. If you think it's mastitis, that will usually have fever. Okay? Inflammatory breast cancer usually doesn't have fever. Put them on antibiotics and make an appointment with me. Get them into a breast image the same day. If it goes away completely, that's great. We can still have a conversation with them. They can cancel their appointment. I don't care. But don't wait. Don't sit on inflammatory breast cancer. That's probably one of the most important things. Because these cancers are horribly aggressive. By definition, it has to arise within 6 months. Okay? Cancer showing its ugly phase in 6 months is scary. So, that's it. Okay, so this is Paget's disease. You know that all the textbook pictures are like textbook pictures, right? That's not how any of them are going to look in real life. So this is pretty aggressive. Like this looks angry. You're going to have more subtle ones in this. Just know that. Inflammatory breast cancer. Okay, that looks like it could be an infection, right? Looks terrible. But that's what inflammatory breast cancer looks like. Okay, the only reason that I put this slide in here is just to tell you guys that there are some times that your patients are going to come see one of us, and then we're going to biopsy them, and they don't have cancer, but I want them to go to a surgeon and cut it out. That's all you got to know. That's it. Okay. There are things that are not cancer that I still won't cut out of the breast. Okay. I put this in because my mentor, this is how she explained breast cancer to patients. And she says it's like a ladder. At the bottom of the ladder, at the ground, you have normal cells. At the top of the ladder, you have cancer. Okay? There are other entities that are marching their way up those rungs. They're not at the top yet. Problem is, they can keep on marching. So we cut them out. That's all you need to know. Then that falls under the atypia. Whenever you hear some breast thing, atypia, know that that is going to go to surgery. Okay? And know that this is a highly contentious part of practice right now. We used to send all things, right? Like radial scars, LCIS, all this other stuff to surgeons because I could have undersampled. Right? And then the other thing about the atypia is I know if there's atypia there that I found on my biopsy of my 1 centimeter cancer or mass or whatever, calcs, she also used this analogy. When I biopsy something, I go around to a neighborhood, okay? I know which neighborhood I'm in, and I knock on a couple doors, right? So I might have found a decent guy who lives there, right? But there could be a meth dealer right next door and I wouldn't know because I only knocked on this guy's door. So this guy has atypia. I got to go make sure that that meth dealer isn't there and that meth dealer is cancer. Does that make sense? So I could undersample. So therefore, these people go to surgery. And I don't think you need to know anything more than that other than the fact that this is contentious. And we're not playing by the rules anymore. It used to be like, oh, you get a radial scar, you always go to cancer. Now we're finding we don't need to do that. And don't worry about that. But know that there are cancerous things. And when your patients are like, oh my gosh, I have to go to surgery for this, but you told me it's not cancer. You can say, well, it's not cancer. The problem is it could become cancer. Therefore, it comes out. Okay, so mastitis, you guys know it's an infection. Fibroadenoma, it's a mass. Young patients, you'll get these. Always, any mass comes to me because you don't want to miss it. When I biopsied my 27-year-old, well, no, when she came in, I saw she had a mass. My first thoughts are like, benign, cancer. That's cancer. Fibrocystic change, know that that's a thing, okay? Your boards may call it fibrocystic, there's no, the old disease. Yeah, so fibrocystic disease, about 50% of women have fibrocystic change. So we figured out that either half of us are diseased or it's normal. So we changed the name from fibrocystic disease to fibrocystic change. Very common. These patients will often have breast pain. Okay? And then cysts are very, very common. People will tell you I have lumps that come and go. Just know that there's a bunch of other stuff that could be in the breast. That's all I really care We're like 5 minutes away from 11, and I'm talking way longer than I thought I would. So let's do this slide and then take a little bit of a break, and then we'll regroup. And so this is something that you guys already know. The vast majority go to the armpit, okay? There's a small percent, especially medial breast cancers, that can go to the primary chain here. And then I think that this would be an unfair question, but just know that the ladies spreads hematogenously, it's the only one that spreads by blood. And then distant mets can be everywhere. And there's really interesting research out there about different types of either genetics or types of breast cancers and how they spread. Some spread viscerally, some like the bone, some like, you don't have to know any of that. But just know that breast cancer spread, okay? Liver, bone, brain. That's probably enough. So, okay, does anybody have any questions thus far? Okay, do you guys want a break or you want to power through? Break, okay, stick with